and he's going to speak about HIPEC in ovarian cancer single center experience. Professor Ahmed Mustafa.
Yes, thank you, Mr. Chairman. Do you hear me now?
Yeah.
And is my screen also visible? Dr. Ahmed?
Yes, we can hear you. Just need to make your sound a little bit louder.
Okay. So my presentation will be about HIPEC in ovarian cancer in National Cancer Institute, Cairo University. We started our program 10 years ago as regards cytoreductive surgery and HIPEC, and we have always to say that CRS plus HIPEC and not HIPEC alone. So 60% of ovarian cancer present with peritoneal carcinomatosis, and although initially responsive, they soon become non-responsive and recur, and they don't have poor long-term survival. The first peritoneal carcinomatosis was presented in ovarian cancer in 1931. In 1978, Didrich et al. First reported higher tumor drug concentration using intraperitoneal chemotherapy without hyperthermia, giving more concentration, 10 to 20 times more for the chemotherapeutic drug. However, in spite of a lot of studies done, only 42% of patients completed their planned 6 cycles because of issues related to the catheter problem, GIT toxicity. Then the first HIPEC report was reported by Spart et al. In 1980. This work was matured in 1990 by Sugar-Baker. There is a lot of studies in HIPEC in ovarian cancer. However, most of these studies are non-randomized comparative studies and observational studies and on a heterogeneous group of patients. So the peritoneal surface oncology group international, it's the famous group dealing with peritoneal surface malignancy. It has a conference or a congress that held biannually. The first congress was in 1998, but when we came back to the 9th congress that was held in Amsterdam in 2014, they concluded that in ovarian cancer, patients may benefit or may profit from this strategy as regard HIPEC, and we need additional evidence. 2 years later, in Washington, D.C., 2016, among the 7 best advices of this international congress, they mentioned that the HIPEC with cisplatinum is active for cisplatinum resistant as well as cisplatinum sensitive recurrent ovarian cancer. Then 2 years later, in 2018, again in Paris, there is no difference. HIPEC may benefit patients with ovarian cancer, and we still need more studies. However, maybe this paper was published last month, 2020, 2021, decision-making analysis for hyperthermic intraperitoneal chemotherapy in ovarian cancer. Among the executive committee of this Congress, they asked 15 of the whole expert surgeons to give their opinion as when and to use HIPEC and if they are going to use HIPEC for ovary or not. and to describe the clinical condition under which they would recommend HIPEC in patients with ovarian cancer. 12 experts had accepted to share in this study. 9 of them accepted to mention that they are going to use HIPEC for advanced ovarian cancer. 5 criteria relevant to the indication to perform HIPEC were founded, whether it's primary tumor or recurrent disease. There are more tendency to use HIPEC with recurrent disease in 75% of them rather than in primary setting. Whether the tumor is resectable, the tumor, you should achieve CC score 0 or maximum score 1, leaving a residual not more than 2.5 millimeter. Of course, there should be absence of distant metastasis. The peritoneal carcinoma index should be less than 21, and it should be an epithelial ovarian cancer. So, which patient that fits? There is a clash. HIPEC is a clash, can be regarded as a classic example of clash between evidence-based medicine and clinical innovation. And the question, if the current evidence is strong enough for us to incorporate HIPEC in all cases, actually we don't have evidence till now to suggest or advocate this. However, there are many time points for patients with ovarian cancer, and these patients may have a potential survival benefit when using cytoreductive surgery and HIPEC in the secondary CRS or in the salvage CRS for recurrent ovarian cancer, and for earlier stages and earlier time points, there is much less evidence for the potential benefit of HIPEC. So HIPEC and NCI, we started in 2010 then to 2011. We noticed that at the beginning there was great enthusiasm and expectations from both oncologists and helpless, hopeless patients with advanced disease. And actually, we couldn't help those patients. So after that, it was a trending, but we soon realized that CRS and HIPEC does not fit all patients. And it's not the magic stick that we can cure patients using HIPEC. And there should be a selection criteria. Also, we realized that there is a substantial morbidity of this procedure. So lessons learned across time. We learned to read the CT proper, to look for the difficult situations in our patients. So we look at the subdiaphragmatic area, looking for metastasis, the endofrown ligament and the hepatorenal pouch, looking for metastasis, liver hilum also, spleen and lesser sac, gallbladder area should be inspected properly, pancreas and spleen, greater omentum, lesser omentum, small bowel disease. This is normal CT. When you have a small bowel disease, you have a nodules entangling the small bowel. You may have small bowel obstruction, mesenteric nodules, either proximal mesenteric nodules or distal mesenteric nodules, large bowel and paracolic disease. When you have the colon adherent to the abdominal wall, this means that you have a disease in the paracolic gutter. The pelvis, either tumor, you may find tumor lateral to the rectum, or tumor between the bladder and the uterus, or between the uterus and the rectum. You should be prepared. Also nodal disease, we have to look for nodal disease in the CT, either in the pelvis, celiac or mediastinal lymph nodes, infrarenal lymph nodes also. Pleural disease is important to look for disease in the pleura. The second lesson was doing diagnostic laparoscopy, and diagnostic laparoscopy is an exit for the patient as well as for the surgeon, not to perform unnecessary surgery. Lesson number 3 was that we have to refine our surgical skills and how we do it. The decision is much easier in the primary peritoneal carcinomatosis and also in early cases of colorectal peritoneal carcinomatosis also. So we learned how to surgically resect difficult areas like in subdiaphragmatic disease, hilum of the liver, heavy pelvic deposits. So we conducted this study on 48 patients with epithelial ovarian cancer from 2012 to 2016. including patient with good performance status and good hepatic and renal function with peritoneal metastasis, excluding patient with distant disease and poor general condition or incomplete cytoreductive surgery. This was a retrospective study, and the median PCI was 6 or 7 in both groups. We have 2 deaths in the cytoreductive surgery and HIPEC group. However, after cytoreductive surgery, CC0 or 1, we performed HIPEC using either closed or open method using cisplatinum, 200 milligram per square meter. We have few mortality, 2 mortalities, and we have 4 morbidities. Pulmonary embolism, we have a case of renal failure, chest infection, and DVT also. In multivariant analysis of prognostic factors associated with lower overall survival, we noticed that ascites and non-serous histological types were associated with statistically significant impact in overall survival, while the presence of ascites was the only factor associated with a statistically significant impact on disease-free survival. There was no statistically significant difference regarding overall survival or disease-free survival between both groups, the cytoreductive group and the cytoreductive group plus HIPEC. So lesson number 4, what if you don't have HIPEC in your hospital? So you have to do optimal cytoreduction in all cases, and this is the backbone of the treatment. Also, it's an anesthetic challenge. This case was one of the earlier cases, and I noticed after I finished that there was a drop in the vital, in the blood pressure at this point, and I asked my colleague, and he told me, I'm waiting for you to finish, then I'm going to replace. So it's a teamwork, and we have to learn all together how to